Well, hi, everybody. It's Dr. Kaylen Silverberg at Texas Fertility in Austin. I sure appreciate your joining us tonight. What we would like to do tonight is to talk about a disease that's very common, affects a lot of our patients, and that's endometriosis. So just to give you a little bit of background, we are located in Austin, Texas. We have offices stretching from Round Rock to our main office, which is where I am right now. Sorry about the clutter that you can see behind me in my office. We have an office in South Austin. We have an office in New Braunfels. We also have one in San Antonio. And then we have another office. Our furthest south office is on the coast in Corpus Christi. So we're so happy that you chose to join us tonight. We are going to take questions about every 15 minutes or so. I anticipate that this webinar will go probably about 45 minutes, maybe an hour, just depending upon how many questions that you all have. I'm happy to take as many questions as you can fire at me. Hopefully we'll get to all the questions, so you can start firing away if you want to. They'll appear in a pop-up, and I'll be able to recognize them, and we'll stop probably every 15 minutes or so and tackle some questions. So what I'd like to do is just kind of give you a little bit of an overview about what my plan is for tonight, and that is I'm going to talk to you about what endometriosis is, how it occurs, how it happens. We'll talk about symptoms. We'll then talk about the staging of the disease, because there are stages of a disease. We'll talk about how you make the diagnosis, and then we'll talk about treatment options. There are multiple treatment options, including an exciting new treatment option that I'll go into at the end if we have some time. So really, just to jump into this to begin with, patients ask me all the time, what is endometriosis? And if I can give you one sentence that really tells you what endometriosis is, endometriosis basically is normal uterine lining in an abnormal location. So the uterus should, as I describe it to my patients, the uterus is like a jelly donut. The muscular walls of the uterus are the outside of the uterus. It's like the dough in the donut. And then the cavity where the baby goes is the jelly in the middle. Okay. And every month you make more jelly. Those cells multiply and divide, and the uterine lining gets thicker and thicker and thicker to prepare a bed for the baby, so to speak. And then if you fail to get pregnant in that cycle, you have a period, and those cells go out. And people who don't understand this say, okay, well, those cells are going to go forward, they're going to go through the cervix, they're going to go into the vagina, and they're going to go out. But what a lot of people don't understand is that 95% of the time, some of those cells go backward, and they can squirt out of the fallopian tube, and those cells are alive, and they can land on the ovaries or the bowel or the bladder, and they attach and they grow. And as they grow, they can form cysts in the ovaries. Those are called endometriomas. So an endometrioma is a cyst of endometriosis. And as these things grow, they also can produce chemicals called cytokines, and cytokines can do different things. So you may not have heard of the term cytokines, and one of the main types of cytokines is something called prostaglandin. You may not have heard of prostaglandin, but you know what anti-prostaglandin medicines are. Anti-prostaglandin medicines are things like ibuprofen, Advil, Aleve, meloxicam. I mean, there's all kinds of different anti-prostaglandin medicines out there. So when endometriosis grows and develops and it produces prostaglandin, prostaglandin causes that cramping that occurs when a woman has a period. Typically, the thicker your uterine lining, the more prostaglandin you produce, and therefore the more cramping that you may have. And this is why one thing that we can do to stop that cramping is to put people on medicines that will cause your uterine lining to get thinner over time rather than thicker. And in fact, when we talk about birth control pills, putting people on birth control pills can pretty much prevent the uterine lining from getting thicker. It can prevent you from having a period if you give birth control pills continuously. And if you're not bleeding forward, you're not bleeding backward either, theoretically. So back to the first point, what is the definition of endometriosis? It's normal uterine lining in an abnormal location. Okay, so what are the symptoms of endometriosis? Well, in fact, there are a variety of different symptoms of endometriosis. Again, if you ask a gynecologist, or if you ask patients who see gynecologists, not for fertility, but just because of discomfort, you'll be told that the most common symptoms of endometriosis, really the most common symptom is pain. Pain with your period, we call that dysmenorrhea. Pain with sex, we call that dyspareunia. Occasionally, you can have pain with bowel movements, that's called dyschezia. Pain with urination, that's called dysuria. But actually, in our practice at Texas Fertility, the most common symptom of endometriosis is actually infertility. So there are lots of studies that have been done that show that women who have infertility are much more likely to have endometriosis than women who do not. And conversely, women who have endometriosis are much more likely to have infertility than the general population. So this is why reproductive endocrinology typically focuses, one of our areas of focus is on the treatment of endometriosis, because it's such a common problem that our patients face. So again, the symptoms that we experience, or that our patients do experience, do include things like different types of pain, dysmenorrhea, dyspareunia. The symptoms may be non-cyclic, or they could be cyclic. If you read textbook chapters, and we happen to write the chapter on endometriosis in Copeland's textbook of gynecology, but if you read chapters in textbooks, for example, it talks about the fact that pain typically is cyclic. In other words, it comes on mainly before period starts. So 2, 3, 4 days before your period starts, you'll start to get a lot of cramping and a lot of fullness, a lot of heaviness, mainly in your pelvis. But the pain can also be non-cyclic. It can get to the point where it really happens every day. It may be localized. You may feel it much more on the right side. You may feel it on the left side. It may be generalized. You can also have gastroenterologic symptoms. So for example, constipation, diarrhea, occasionally blood in your urine, blood in stool, things like that. You can have urinary symptoms as well, like dysuria, hematuria, so blood in the urine, or pain when you urinate, or urinary urgency, urinary frequency as well. If you look at the association between endometriosis and chronic pelvic pain, that's a real common thing. So a lot of women who have long-lasting endometriosis develop chronic pelvic pain. And chronic pelvic pain is a big problem in the United States. It affects about 15% of all women of reproductive age. In other words, about 9 million women. Of those patients, only about 10% ever go seek help from a gynecologist. In fact, 75% of women with chronic pelvic pain don't seek help from anybody. They just suffer, usually in silence, but really, the more they suffer, the less silent it becomes. But unfortunately, for 75% of women, the pain is not bad enough that forces them to either go to the emergency room or go seek help from a medical professional. It's got a huge cost to society. 10% of all gynecologic visits in the United States are because of endometriosis or chronic pelvic pain. 40% of laparoscopic procedures that are performed in the United States are performed for either endometriosis or chronic pelvic pain. And 10 to 15% of all hysterectomies are performed because of chronic pelvic pain or endometriosis. So again, what causes endometriosis? It's this backward or retrograde menstruation. So what do you have to have in order to develop endometriosis? Because there's certain things that have to happen. Not only do you have to have a period, not only do those cells have to go backward, but those cells then have to attach to the ovaries, the bowel, the bladder, the sidewall of the pelvis. They have to invade in those tissues. Blood vessels start to come into that area, a process called angiogenesis. And then you get inflammation or an immune response. And that's really what causes a lot of the symptoms and a lot of the problems. So if we can move on now that we've talked about symptoms to talk about staging of endometriosis. Endometriosis does have 4 stages, stage 1 through 4. Stage 1 is called minimal disease. Stage 2 is called mild disease. Stage 3 is called moderate disease. And stage 4 is called severe disease. And this is not a situation where you lick your finger and you hold your finger up in the air into the wind and you say, well, gee, that looks like stage 2 disease or stage 3 disease. There's actually a scoring system that's put forward by the American Society for Reproductive Medicine. And you actually get points for different types of lesions and different types of scarring as well. So for example, with stage 1 disease, you have a score of 1 to 5 points. So typically this is accounted for by isolated little lesions on the ovary, isolated little lesions on the sidewall of the pelvis, maybe on the bowel or on the bladder. These lesions can have a variety of different appearances. They can have a variety of different colors. So when I was in residency, we were taught that blue lesions, blue endometriotic lesions or dark lesions are the worst. They're the ones that cause the most pain. But several studies have been done much more recently that suggest that these blue or black lesions really are burned out lesions of endometriosis. They're not what are called mitotically active. In other words, those cells that form those colored lesions are not actively dividing. And so this is not the type of endometriosis that may be rapidly progressive. But regardless, if we see blue lesions, red lesions, clear lesions, white scarred lesions, we treat them all. We'll talk about how we treat them in a few minutes. But so to get back to the staging, stage 1 disease, where you have a score of 1 to 5 points, typically involves just little isolated lesions around the pelvis. Once you get into stage 2 disease, that's where you may start to see scar tissue development. So we know that endometriosis, because of the inflammation that it causes, the inflammatory response, and the immune response that it causes, can also cause scar tissue formation. So you may get lesions on the ovary. So when you have a period, those cells come out of the fallopian tube, those cells land on the ovary, they attach and they grow. And as they grow, they become sticky, and they can make tissue form between the ovary and the sidewall of the pelvis, or between the ovary and the fallopian tube, or between the ovary and the intestine, and maybe and frequently between the ovary and the back of the uterus. And this is where you start to get a lot more discussion of pain, and a lot more evidence of pain that comes along with periods or between periods or with sex. Once you get into stage 3, now you've got a score of 16 to 40 points. So again, to reiterate, stage 1 disease is 1 to 5 points. Stage 2 disease is 6 to 15 points. Stage 3 disease is 16 to 40 points. And now when you get into stage 3 disease, typically what you have is a development of an endometrioma. So what happens now is those cells come out of the fallopian tube, they land on the ovary, and every month as your uterine lining cycles, those abnormal cells that are in an abnormal location start to cycle also. So you can get invasion of those cells into the capsule of the ovary, and then every month those cells bleed about the same time that you're having a menstrual period. And so you can get the formation of a little bitty cyst, and month after month after month of bleeding, that cyst gets bigger and bigger and bigger and bigger and bigger until it becomes really, really obvious, either because it's causing more pain, pain with your period, pain with intercourse, or because you feel a mass, or because you go to your gynecologist or you go to your fertility doctor, they do an ultrasound and they see a mass, they see a lesion, okay? And that cyst is obvious as an endometrioma. And then you need to have that treated, obviously. And then beyond stage 3 disease is where you get to be stage 4 disease or severe disease. This is a score of 41 points or more. And typically with stage 4 endometriosis, everything is stuck to everything. So the ovaries you typically have endometriomas in both ovaries, and they can get to be so big and so heavy that because of gravity, they fall behind the uterus. They fill the top of the vagina. So when you're doing a gynecologic exam, a manual or a digital exam, you put your fingers inside the vagina, and at the top of the vagina, you feel a bulge, you feel a mass, which is these cysts of endometriosis in the ovary pushing down into the vagina. And typically what will happen is this endometriosis on the surface of the ovary is sticky, and the ovaries may actually stick together. They may stick to the back of the uterus, stick to the rectum, stick to the sidewalls of the pelvis, and that leads to a big problem. So I'll take one question that popped up already. Why is there a correlation between endometriosis and infertility? A couple of different answers. So first of all, when you have stage 3 or stage 4 disease, when you have advanced disease, as you can tell from the description that I just gave you, if the ovary is stuck, say the ovary is stuck to the back of the uterus, okay? If you ovulate on the surface of the ovary that is not stuck to the back of the uterus, that egg can then get out and may actually get picked up by the fallopian tube and may fertilize and lead to a pregnancy. But if, on the other hand, your egg develops in the part of the ovary that's stuck to the back of the uterus, ovulation can still occur, but that egg has no way of escaping from that scar tissue and getting into the fallopian tube. So one way that endometriosis causes infertility is that when ovulation occurs, that egg doesn't get picked up by the fallopian tube. And that's a deal breaker right there. Pregnancy is over for that cycle. There's no hope. The egg's not going to get picked up by the tube. It's not going to fertilize, and pregnancy is not going to result. Okay, a second problem is that even with less severe disease than stage 3 or stage 4, that endometriosis, those cells make other types of cytokines that can interfere with sperm-egg interaction, so they can block fertilization, or they can also block implantation. In fact, there is a new test out now called the Receptiva test, where we can actually do an endometrial biopsy, take a little piece of tissue out of the uterine lining, and we can screen those cells for biomarkers that are associated with endometriosis. And we know that when you have endometriosis and those biomarkers are altered, then the receptors for a pregnancy within the uterus are diminished. And so we get a decrease in the likelihood of implantation. So you may ovulate beautifully, you may have sex at just the exact time, your fallopian tubes may be terrific, and the egg may get picked up by the fallopian tube, the sperm sample may be terrific, and the egg may fertilize, but when that egg travels down the fallopian tube and goes into the uterine cavity, because of alterations in protein production in the uterus itself, we may not get implantation or attachment. So those are the three basic mechanisms that are involved for the way in which endometriosis can interfere with pregnancy. Now, there's one other way as well, and that is if you have a big cyst in the ovary, there is less room for eggs to develop. So ovulation may be disordered also. And so that actually is a fourth way. So what about diagnosis? How do we diagnose endometriosis? Classically, we diagnose endometriosis because of the development of symptoms. Patients have increasingly severe pain with their periods. They may have, and let's talk about that for a minute. The goofy thing about endometriosis is that the severity of the disease and the severity of the symptoms have nothing to do with each other. So if I can use my hands to talk here for a minute, in medicine, we like graphs. So if you look at a graph and you see that my left hand, or the axis that goes up, the y-axis, is the severity of the disease, and the x-axis is the severity of the symptoms. What we like to see is we like to see a line that goes like this. So the worse the symptoms get, the more advanced the stage of disease is. So it would be great if I could say to you, you know what? Women who have really severe symptoms of endometriosis usually have stage 4 endometriosis, really severe disease. Women who have minimal symptoms of endometriosis just have stage 1 disease or minimal disease. The problem is that's not true. With endometriosis, what we really see is a scattergram. So I've taken women to surgery who have horrible pain, and I put a laparoscope in their belly button, and they may have 1 or 2 little implants of disease. And we vaporize that, and after surgery, they think we're geniuses. They feel great. And on the other hand, we've taken women to surgery who have huge masses in their ovaries, big cysts of endometriosis. And we get in there, we strip out their cyst, but they're really not having much pain to begin with. We still go ahead and treat the endometriosis. We get rid of those cysts because we know that they can affect their fertility. And typically this is why we're operating on women, for endometriosis. But the bottom line here is that unlike most diseases, with endometriosis, the severity of the disease and the severity of the symptoms have little to nothing to do with each other. So it's been about 15 minutes. I'm going to take a couple of other questions here. One question is, let's see. Are women with endometriosis more likely to have an ectopic pregnancy? Well, that's a very interesting question. We know that if you get scar tissue, because remember I said already that endometriosis can cause scar tissue, and if you get scar tissue around your fallopian tubes, yes, you're more likely to get an ectopic pregnancy. So in general, endometriosis does not cause tubal pregnancies, but the scarring that can result from endometriosis may actually cause an increase in the risk of tubal pregnancies. Next question, can you see an endometriosis cyst on an ultrasound? And the answer is frequently you can. So ultrasound is limited by a bunch of different factors, mainly the physics of the machine and the physics of the sound waves. But if you have a mass in the ovary, a cyst in the ovary, we ought to be able to see it. Usually it needs to be 10 millimeters, 1 centimeter or larger to be able to see it. But at that point in time, we really ought to be able to see it. Now, ovarian cysts are real common and they've got different appearances. First of all, they're different kinds of cysts. They're what we call functional cysts or simple cysts. And these look like black circles in the ovary. The basic rules of interpreting ultrasound: fluid is black, bone and air are white, and everything else are different shades of gray. So really what we're trying to do when we're reading an ultrasound or we're performing an ultrasound, we're trying to interpret shadows. So when we see a black structure, a black circle in the ovary, that represents either a developing follicle, because follicles are just fluid-filled sacs that have an egg inside and millions of granulosa cells. Or it could be what we call a simple cyst. So maybe you make a cyst or maybe you make a follicle in a given month, but for whatever reason, that follicle doesn't ovulate. It just gets bigger and bigger and bigger. And then when it doesn't ovulate, it stays as a cyst. and gradually and eventually that cyst will go all by itself, be reabsorbed into the ovary, and you don't have to worry about it anymore. And that cyst, a simple cyst, has a characteristic appearance that looks just like a follicle. It's a black circle in the ovary. Okay? There are other types of cysts. For example, you may have a dermoid cyst. And you may have heard of dermoid cysts. Those are the kinds of cysts that have hair in them. They may have tooth. They may have some brain tissue. They're kind of disgusting. But anyway, long story short, those cysts typically have different densities inside. So for example, a tooth, would have density of calcium. It would be very, very dense, and it would show up therefore as bright white, almost like bone. And so if you see that in a cyst, that's pretty characteristic for a dermoid. An endometrioma is in between those two. It's not black and it's not white. It's kind of gray. And the classic appearance that's described in textbooks is a ground glass appearance. So it's kind of like you grind up glass, and it's got kind of a pretty characteristic appearance. I can't describe it, but it's just, you know it when you see it. So that is pretty characteristic of endometriosis. The problem is endometriosis fluid is old blood. And so endometriosis and blood have the same consistency. And therefore, it's easy with ultrasound to confuse an endometrioma with a blood-filled cyst. Now, you may say, well, why would I get a blood-filled cyst? And the answer is every month, if you ovulate regularly, when you're making a follicle, that follicle gets bigger and bigger and bigger. And when it's time to ovulate, that follicle wall tears so that the egg can come out. Okay? Where that follicle wall tears is random. And there are blood vessels that course over the surface of the ovary all over the place. And so if that follicle wall tears and it tears a little blood vessel, you'll get bleeding. Now, sometimes, usually, that bleeding occurs into the follicle itself. So now you may get expansion of that follicle or that cyst, and it's what we call a hemorrhagic or blood-filled cyst. Okay, no big deal. Almost always that takes care of itself and goes away also. But that hemorrhagic cyst and an endometrioma can look the exact same on ultrasound. So how do we tell the difference? Well, like I said, hemorrhagic cysts over time will shrink and go away and be reabsorbed into the ovary, whereas the endometrioma persists. And so what we'll do is, if we see something like that that's suspicious for an endometrioma, either we'll put you on nothing and have you come back in a couple of weeks and we'll take a look at it again. If it's a blood-filled cyst, by that point in time, it should be smaller or maybe even gone. If it's unchanged or maybe slightly bigger, then we worry that, maybe it's more likely to be an endometrioma. If that happens and the cyst doesn't go away within a couple of weeks, typically we'll put you on a birth control pill to block stimulation of the cyst by the pituitary gland, that little pea-sized gland that lives behind your nose. And that gland secretes a hormone called FSH, follicle stimulating hormone. And FSH is the hormone that makes follicles or cysts in the ovary potentially grow. So by giving you birth control pills, we can turn this off. We can block the stimulation of a cyst, and that raises the likelihood that a cyst may decrease or go away faster. And this is why a lot of people give birth control pills when women have cysts. Okay, next question, the difference between excision and ablation. We'll talk about that in a few minutes when we go to treatment. Can a woman have both PCOS and endometriosis? Absolutely, they have nothing to do with each other. So that's like saying, can a woman have a broken arm and a headache? Of course. Okay, they don't have anything to do with each other, but you can get both of them. PCOS, polycystic ovarian syndrome, is a condition in which not only do you not ovulate regularly, but you also have typically hyperandrogenic symptoms. So you might have a lot of hair growth on your face, your sideburns, your lip, your chin, maybe some hair around your breast, things like that. You can also have impaired glucose tolerance. So with PCOS, one of the tests that we do tests your ability to metabolize glucose. So we do a test called a 2-hour glucose tolerance test. We'll send you into the laboratory fasting. They'll draw your blood. You'll then drink something like Gatorade or some sugar water. And then an hour later and an hour after that, so 1 hour and 2 hours after you drink this liquid, they'll draw your blood. And then we look at those 3 levels of glucose. Normal people who metabolize glucose normally will see a relatively low level of glucose. They may get a little spike, but then it's metabolized and goes back down. Women who don't metabolize glucose regularly they have something called the Metabolic Syndrome, and that is one of the symptoms and one of the things we see with PCOS. So therefore, at least 2 out of the 3 blood levels that we get of glucose are out of whack. They're elevated. And that tells us that those women are not processing glucose like they should, and they have polycystic ovarian syndrome. So what we're really telling you, if we tell you that you have PCOS, this is a totally different lecture, but what we're really telling you if you have PCOS is not only do you not metabolize glucose and not only do you not ovulate regularly, but you have a statistically significantly increased risk of high blood pressure and maybe even diabetes requiring insulin later in life. So it's very important that those be treated. But the bottom line is PCOS and endometriosis really don't have anything to do with each other. Next question, are there any diet or lifestyle behaviors that can reduce endometriosis pain or boost fertility? And the answer really is no. It's better to try and get pregnant when you're younger because that does decrease the likelihood of developing endometriosis. If your mother or your older sister or your aunt has endometriosis, that means that you do have an increased risk of getting endometriosis yourself. So you may want to think about maybe conceiving a little earlier than you might have otherwise planned. Because we know that the best treatment of all for endometriosis, and I'll say this again in a few minutes, but the best treatment of all for endometriosis is pregnancy. It's better than medicine, it's better than surgery. Frequently, women who have endometriosis end up with infertility. They come to see us. We have to go through a lot of different treatment to help them conceive. But once they have a baby, pregnancy is almost like hitting the reset button on the pinball machine. Now, all of a sudden, they've been pregnant, their endometriosis regresses, and then because they don't have active endometriosis anymore, they may be able to conceive easily by themselves. And you'll hear these stories all the time. They're written up all over the place. This couple had to go through fertility treatment. It was very trying, very expensive. It took a long time. Eventually, they got pregnant and had a baby. And then, lo and behold, baby number 2 and baby number 3 came easily and spontaneously. Well, that's not a mystery. The reason that happens is because they may very well have had problems like, some types of blockage of the fallopian tube that get corrected. Maybe she didn't ovulate regularly. And all of a sudden, after pregnancy now, that's fixed and she can ovulate regularly. Maybe she had endometriosis. And now because of pregnancy, the endometriosis goes away and it's easier to conceive. So back to what we're talking about before, and then we'll come back to questions again in just a few minutes. What are treatment options for endometriosis? Well, the treatment options for endometriosis are trying to mimic things that happen in nature that cause endometriosis to regress. So one thing is pregnancy. So there are what are called pseudo-pregnancy regimes. And this mainly consists of birth control pills. So when we give birth control pills, we are giving both estrogen and progesterone. Okay? Now, endometriosis is fueled by estrogen. So estrogen, said another way, estrogen is the fire that makes is the fuel that makes the endometriosis fire burn. So we know that in pregnancy, estrogen levels go up and progesterone levels go up. But progesterone levels typically go up greater than estrogen levels. And we know that estrogen and progesterone have different effects on uterine lining. And you remember I told you at the very beginning that endometriosis is normal uterine lining in an abnormal location. So what happens is when you bleed forward, you're bleeding backward as well. If we can stop you from bleeding forward, then we can theoretically stop you from bleeding backward. So by putting you on a very low estrogen dose birth control pill, because remember, estrogen causes the uterine lining to get thicker over time, progesterone causes the uterine lining to get thinner over time. So you may remember when you were young, when you went through maybe in your teenage years, you might have started birth control pills for bad cramping with your period. And you may have noticed that the longer you were on birth control pills, the lighter and lighter and lighter your periods became. No mystery as to why that happens. The reason that happens is because over time, because most birth control pills are progesterone dominant, your uterine lining gets thinner and thinner and thinner and thinner. And the thinner your uterine lining gets, the less tissue there is to come out, so your periods get lighter. And when you don't bleed forward, you don't bleed backward either. So therefore, putting people on birth control pills is a very simple, very easy thing to do. Okay? Another way to treat the symptoms of endometriosis is to give anti-prostaglandin medicine. So typically we give ibuprofen or naproxen sodium. So typically those are Advil or Aleve. And we know that those medicines block a hormone or block an enzyme called prostaglandin synthetase. And that is an enzyme involved in producing prostaglandin. And we know that prostaglandin is, again, what causes that muscle, that uterus, to contract, and that's what causes pain. And so if we can block prostaglandin production by giving ibuprofen, naproxen, Advil, Aleve, things like that, if we can do that, then we can very effectively decrease the volume and decrease the severity of cramping. So that's important also. Now, you remember I told you a minute ago that estrogen makes uterine lining get thicker, progesterone makes uterine lining get thinner, and that we give birth control pills, and that I've already told you that estrogen is public enemy number one. So the question I would be asking if I were you, a lot of the questions that my patients ask is, why would you give me a birth control pill? Why would you give me any estrogen? The answer is estrogen is the feel-good hormone, and progesterone is the feel-crappy hormone. So ideally, we would rather not give you estrogen. Ideally, we would rather give you progesterone, either a natural progesterone or a synthetic, more potent progesterone. Because again, progesterone causes your uterine lining to get thinner over time. And if we do that, that's great. That really helps us because it minimizes the volume of bleeding. The problem is progesterone has nasty side effects. So progesterone causes you to be moody. It causes your breast to be tender. It may cause you to have more cramping. It may cause you to be constipated. It may cause you to be sleepy. So because of those things, women don't really like progesterone. You may notice early in pregnancy, for those of you who've been pregnant, early in pregnancy, you get so sleepy. Well, the reason you get so sleepy is because your progesterone production is high. So if we give women progesterone, absolutely, we will achieve the ultimate goal of decreasing the thickness of the uterine lining, decreasing the amount of blood that goes out forward or that goes backward. But the problem is it comes at a cost. And that cost may be your relationship. I mean, not to exaggerate, but you know, it's tough to be on progesterone alone. So therefore, we tend to moderate that by giving a little bit of estrogen also. And this is why we give a low-dose birth control pill. Now, again, this is another topic, but when we talk about low-dose birth control pills, what we really mean is low estrogen dose birth control pill. The progesterone dose in a low-dose pill is actually pretty high, and it's relatively higher than the estrogen. So we're getting net the effect that we want. It's like we're giving progesterone, so we're making that uterine lining get thinner over time, which is really going to help us. But on the other hand, we're giving estrogen in just enough of a dose to counteract the effect of the progesterone. Okay, so women don't have as much breast tenderness. They don't have as much moodiness. They don't have as much sleepiness. They're a little more energetic, a little peppier. But what we try and do is we try and give the lowest estrogen dose possible to prevent rekindling of that endometriosis. And we'll talk about this again in a minute when we talk about GnRH analogs. So to move on a little bit, we've talked about birth control pills. We've talked about non-steroidal anti-inflammatories. We talked about progesterone. There is a drug that used to be out called Danazol. And Danazol is a testosterone derivative, and it does work against endometriosis. But the problem with Danazol is that it causes a lot of testosterone side effects. So, for example, you can get temporal balding as men get older. Don't look at me, but as men get older, their hairline tends to recede. They tend to get temporal balding. They may get some thickening of their vocal cords, so their voices get lower. And these are side effects that we're seeing in women. So women who took Danazol had temporal balding. They had thickening of the vocal cords, and sometimes that was not reversible. They had excessive hair growth in parts of their bodies where they might not have wanted excessive hair growth. So that's an issue, and that's a problem. The next two categories of drugs that we're going to talk about are GnRH analogs, and those are agonists and antagonists. But before we talk about that, I'm going to actually, you know what? I'll talk about that first, then I'm going to talk about surgery. So there's two types of GnRH analogs. There is a GnRH agonist that turns the pituitary gland on, and there's a GnRH antagonist that turns the pituitary gland off. Okay? And why am I talking about the pituitary gland? Why is this important? So to refresh your memory, the pituitary gland, that little pea-sized gland that lives behind your nose, makes a hormone called FSH. Excuse me. FSH stands for follicle stimulating hormone, and FSH travels from the pituitary gland through your circulatory system to your ovaries, and it stimulates the ovaries to make estrogen. Again, estrogen being public enemy number one, estrogen being the source of growth for endometriosis. We want to turn that off. And the way we turn that off is to give you a hormone that is like the native hormone that's made by a part of your brain called the hypothalamus. And that hormone is called Gnrh. And that hormone is made by the hypothalamus, and it travels down to the pituitary gland and stimulates the pituitary gland to make the hormone that eventually makes estrogen. And I know this is complicated, and I'm sorry I'm running through it kind of quickly. But the bottom line here is that if we can give you one of two different types of drugs that either turns this pituitary gland on or off, we can block effectively, very effectively, we can block FSH production. And if we block FSH production and turn off the pituitary, we block estrogen production. And now we've achieved our goal of burning out the endometriosis because we've sucked the estrogen out of the room. Okay, so let's talk about the two different types of Gnrh analogs. One that's been out for 25, 30 years now is a Gnrh agonist, and that's called Depo Lupron. Okay, and what Depo Lupron does, it's an agonist, so it turns the pituitary gland on. So when you get a shot of Depo Lupron, for about 5 days, it stimulates the pituitary gland and causes the pituitary gland to make a lot of FSH, and that FSH then travels through the circulatory system to the ovaries, causes a lot of estrogen production. So for 5 days, that Gnrh analog, that Gnrh agonist, can actually make endometriosis symptoms worse, or it can make a cyst develop in your ovary. So we've got to be very careful about when in the cycle we give it. But this drug is typically given by injection. It's given either once a month or once every 3 months. And what it does is, after it turns the pituitary gland on for 5 days, the pituitary gland flips off. So it will stop making FSH, and we will have shut down the pituitary gland, which is our goal. Now, that all sounds well and good. So why don't we give it to everybody? Well, number one, it's given by injection. Some people don't like injections. I hate injections. Number two, it's very expensive. And so it's a drug that costs a lot of money. It's usually covered by insurance, but we can get, hopefully we can get your insurance to cover it, and that helps. Number three, it causes a lot of vasomotor side effects. So what I mean by that is it puts you into a temporary reversible medical menopause. And so what I mean by that is you will get side effects. You will get hot flashes, vaginal dryness, up to a 6.3% reversible bone mineral density loss. And so we have to give a hormone like estrogen or like progesterone, what we call add-back therapy, to block those side effects. So now we've given you a medicine that's very effective at treating endometriosis, and it works amazingly well. But on the other hand, it's going to be in your system for at least 30 days. Some people don't like that. Some people don't like the fact that it can cause hot flashes, vaginal dryness. So we then have to give another medicine to block the effects of that medicine. So anyway, let's take some questions. Again, excision and ablation, I'm going to talk about that in a minute. PCOS, we talked about that. Okay, when should you test for endometriosis in the fertility process if you have a strong family history? Should an OB-GYN or a fertility doctor perform this? Well, I'm obviously biased. So number one, if you have a family history of endometriosis, you need to be tuned into that, and you should be seen much earlier in the fertility process. So just like if you know your periods aren't regular, you should go see somebody, you should go see a fertility doctor early when you're first starting to get pregnant, because what is waiting a year going to achieve for you? You're not going to all of a sudden start ovulating regularly, so you've wasted a year. Similarly, if you know that you've got a family history of endometriosis, or you have symptoms yourself, increasingly severe pain with your period, pain with sex, pain with bowel movements, go see somebody. You know, either go see your gynecologist or preferably go see a fertility specialist if you're trying to get pregnant. Gynecologists and fertility doctors do not have the same amount of training. So everybody, fertility doctors and OB-GYNs, all do 4 years of OB-GYN residency. So everybody's gone to college, everybody's gone to medical school for 4 years, everybody does a 4-year residency. OB-GYNs then go into practice. They deliver babies, they monitor women in pregnancy, they do hysterectomies, they fix bladders, they do pap smears, they serve as primary care doctors for women. Huge amount of things that OB-GYNs are responsible for. OB-GYN is a very difficult specialty, okay? There are subspecialties of OB-GYN. So in other words, after I did 4 years of Ob-Gyn residency, just like Dr. Vaughn, Dr. Hanser, Dr. Berger, Dr. Probst, Dr. Hudson, Dr. Munch, we then went on and did a fellowship, which was either 2 or 3 additional years of training just in infertility. So what did we learn during that time? We learned about endometriosis and how to treat it. We learned about complicated laparoscopic surgery, complicated hysteroscopic surgery. We learned about ovarian stimulation to help people get pregnant. We learned about in vitro fertilization, and we learned about recurrent pregnancy loss. So really, those are the things that we do. So even though we are all board certified in Ob-Gyn, we don't deliver babies, we don't do hysterectomies, we don't fix bladders, we're not primary care doctors for women, we don't do any of those tons of things that Ob-Gyns do. So again, my bias is that if you have infertility, go see a fertility doctor, and go see a fertility doctor sooner rather than later. Let's see, next question. Can you get endometriosis in the middle of an IVF cycle if you've been doing treatment for over a year? The answer is no, you shouldn't. Endometriosis is not a condition that develops in a couple of days. Endometriosis is a condition that develops over weeks to months to usually years. So endometriosis doesn't start at stage 4. Endometriosis starts at stage 1. So you may have a couple of little implants of disease, but maybe you have a very aggressive form of endometriosis. Or maybe your body doesn't recognize that endometriosis as foreign, and it grows very fast in your particular body because of how you respond. Then you're going to be more likely to get stage 3 or stage 4 disease sooner. But again, endometriosis takes months to typically years and years to develop. So no, you certainly wouldn't get endometriosis in the middle of an IVF cycle. Now, you could get a cyst in the middle of an IVF cycle, or you could get a blood-filled cyst in the middle of an IVF cycle that looks like endometriosis, but typically it's not. Next question, does endometriosis surgery increase the risk for IUI or IVF later? No. The surgery itself, and we'll talk about surgery in just a minute, but the surgery itself does not increase your risk of needing IUI or IVF. It's what we find in surgery that may necessitate IUI or IVF. So for example, let's say you've gone through a fertility evaluation. You've been trying to get pregnant for a couple of years. You go through a fertility evaluation and you get an HSG. And the HSG, that x-ray where the radiologist injects dye through the cervix into the uterus and out the tubes. Let's say that HSG is normal. Your uterine cavity is beautiful. Your fallopian tubes are wide open. You're going to say, well, wait a minute. Why am I not getting pregnant? My partner's got great sperm. I'm ovulating regularly. Here's the x-ray. My uterine cavity is beautiful. My tubes are normal. They're wide open. What's the problem? We may scope you and we may find out that even though your tubes are open and your ovary is there, your ovary has got endometriosis on the surface and it's stuck to the uterus. It's stuck over here. The fallopian tube is stuck over there. And that uterus, and that fallopian tube and that ovary haven't seen each other in a decade. No way for that egg to go from the ovary into the fallopian tube. So even though the fallopian tube is open, even though you're ovulating, it's almost irrelevant because there's no way for that egg to get into the fallopian tube. So the surgery that we do where we diagnose that and we treat it doesn't cause you to have IUI or IVF. The problem is that your tube and your ovary are not associated with each other, and you need IVF anyway in order to be able to get pregnant. Now, the other part of your question, what you may be getting at is, can surgery cause scar tissue formation? And the answer is absolutely. Surgery can absolutely cause scar tissue formation. And as fertility surgeons, reproductive endocrinologists, we are tuned into that. And so we are therefore trained in special techniques to prevent or minimize or lessen scar tissue formation. So for example, let me give you an example. Anytime we see an endometrioma, we see a cyst of endometriosis in the ovary, we're going to make an incision over the capsule of that ovary. We're going to very carefully peel back the capsule of that ovary. We're going to strip out that endometrioma, okay? But then we're not done. Most gynecologists, when they do surgery, that's what they're trained to do. They're trained to either drain the endometrioma or maybe you strip out the endometrioma and then you're finished. We're not finished. We're then going to take suture about as big around as an eyelash and microsurgically through the laparoscope, we're going to close the capsule of that ovary. And the reason we do that is because the inside of that ovary that would be exposed if you just took out that endometrioma and left a gaping hole in that ovary, that inside is very sticky. And it would stick to the side wall of the pelvis or the back of the uterus or the intestine or maybe the bladder. And when that happens, it decreases the likelihood of an egg being able to come out of that ovary and be picked up by the fallopian tube. So therefore, it's very important, and this is why I think, my bias is very clear, and that is that fertility surgeons should be doing fertility surgery. If you've had 2 or 3 kids, you're finished with your childbearing, and you've got endometriosis, go to your gynecologist. They can vaporize little implants of endometriosis, or they can do a hysterectomy if that's what you decide you want. A lot of women these days are deciding that they really don't want a hysterectomy because they know that the uterus does other things besides carry a baby. The uterus is partially responsible for a sexual response. So when a woman has an orgasm, part of that enjoyable feeling is because of mild contractions of the uterus. If you take the uterus out, you're going to lose that part of an orgasm. The uterus is also important because it helps keep structures around the uterus in place. So the bladder sits on top or in front of the uterus. If the uterus is there, it helps keep the bladder where it's supposed to be. If you take the uterus out, now there's a gap, there's a space, and the bladder may very well fall into that space. And that can lead to symptoms like, leaking urine when you sneeze or cough or laugh, or having to run to the bathroom and urinate more frequently. Same thing with the rectum. The rectum is kept in place because the uterus is there. And if you take the uterus out, the rectum may protrude into the vagina. You may have other problems with constipation, things like that. So let's see. If endometriosis is very prevalent and leads to infertility, can endometriosis be used as a treatment code when receiving fertility treatment for insurance? Okay, that's a great question. We get asked this question all the time because, unfortunately, insurance companies still, to a large degree, and things are getting better, but still to a large degree, insurance companies don't cover infertility. So patients ask me all the time, can you please put endometriosis down as my diagnostic code? Can you please put something besides infertility? The answer is, if you are coming to see us for endometriosis, anything that we do related to endometriosis can and should be coded as endometriosis, either diagnosis or treatment. The problem is, after you've been treated for endometriosis, if you're now doing in vitro fertilization, even if you're doing it because you have endometriosis as scar tissue, we're not treating you with in vitro fertilization to treat your endometriosis. We're treating you with in vitro fertilization to treat the infertility caused by the endometriosis. Now, you may say that's just semantics and that's just a word game. It's actually not. It's actually very serious, because if we code procedures done for treatment of infertility, if we code that if we code that intentionally, incorrectly, even if it's for a good cause to try and help you get better coverage, we've now committed insurance fraud. And for insurance fraud, there are pretty severe penalties. Number one, we can lose our insurance contracts, which put us out of business. Number two, we can go to jail. Okay, so we absolutely do not do that. And I know I've been told anecdotally, I've had patients who come to see me and they're like, oh my God, if you're going to code my IVF cycle as infertility and not endometriosis, I'm going to have to pay for it out of pocket. I'm going to have to go see somebody else, because I've been told, my friends told me that somebody else in town may code this as endometriosis, not as infertility. I have to tell you, unfortunately, I'm so sorry, but you have to go somewhere else, because we can't do that. We can't break the law to try and get you better insurance coverage. So anyway, next question. If you, let's see, if you haven't conceived in 6 years, you went through IVF, you miscarried, your one normal embryo, 33 eggs retrieved, would you recommend IVF again? Different topic, but yes, I would need to see, obviously we need to look at the chart, review it, and see what we can learn. Because if you have 33 eggs retrieved, you shouldn't end up, number one, with just one normal embryo. There's something wrong there. And number two, if you miscarried that one normal embryo, there's something wrong there as well. So I would encourage you to talk to your fertility doctor to get it to try and figure out what the problem is there.
Hi, Dr. Silverberg. Just a quick note. We have about 10 minutes left in our webinar. So if you want to wrap up your last section, answer a few questions.
Got it. Thank you for the help. So meanwhile, let's go back to what I was going to talk about before. We talked about Gnrh analogs or Gnrh agonists like Depo Lupron. There's a newer drug out on the market called Oralissa, and that is a Gnrh antagonist. It works by turning the pituitary gland off immediately. So remember with Depo Lupron, it turns the pituitary gland on for about 5 days before it turns it off. So symptoms can actually get worse, and it's given by injection. With Oralissa, it's a pill. It starts to work within 6 hours. Okay, it's a very, very effective pill. It's been shown to be very effective against cramping with periods, pain in general, and also pain with sex. There are no studies yet to show whether it causes endometriosis to actually regress like Depo Lupron does, but those studies are in process right now. So it does give women another alternative. Again, this is a pill. It can be given as 150 milligrams once a day for cramping with periods, or it can be given as 200 milligrams twice a day for pain with intercourse. Very effective treatment. And then there's surgical treatment. And surgery can range anything from laparoscopic surgery, which we've kind of been talking about or talking around it, all the way up to hysterectomy. And some people think that hysterectomy is a panacea for endometriosis, that, oh my gosh, I've tried everything that I can do, I'm going to go ahead and have a hysterectomy. Well, actually, 6% of women who end up having a hysterectomy for endometriosis still have persistent pain even after their hysterectomy. So I encourage you to evaluate all of your options before you decide that you want to proceed to a hysterectomy. So how do we treat endometriosis surgically? The main way that we do it at Texas Fertility is through a procedure called laparoscopy. Laparoscopy is an outpatient day surgical procedure where we take you to the operating room, put you to sleep, make a little bitty incision the size of the tip of your little finger in your belly button, insert a needle, inflate your abdomen with carbon dioxide gas, and then we make 1 or 2 other little bitty incisions just below the top of the pubic hair line, one on the left, if necessary, one on the right. And those are for our toys, our lasers, scissors, graspers, things we need to use. The first thing we do is we put a telescope with a light on the end of it and a camera through your belly button into your abdomen, and we can look around the pelvis. We can look at the liver, the gallbladder, the appendix, the uterus, the tubes, the ovaries, the sidewalls. We can see pretty much everything. We take pictures. We give you a complete set of pictures 2 weeks later. If we see endometriosis, okay, then we can go ahead and either biopsy it, excise it, or vaporize it, okay? There's lots of controversy in our specialty about what the right treatment is. Years ago, there were studies that were published that suggested that if you have endometriosis, you should excise it rather than just vaporize it, okay? And there was one large study that suggested that, in fact, that gave women a better outcome long term. When you break that study down, what they're really referring to is an endometrioma, a cyst of the ovary. And we all agree now that endometriomas should be excised. They shouldn't just be drained, because if you just drain an endometrioma, almost always it will come right back. Usually within a couple of months, the endometrioma is back, sometimes to its original size. You shouldn't just open up the capsule of the ovary and take the endometrioma out and leave the capsule open. You need to do that. Plus, you need to close the capsule of the ovary back together microsurgically so that you can get a minimal amount of scar tissue, hopefully no scar tissue, and hopefully save the ovary. Okay? A lot of gynecologists, unfortunately, if there's a big endometrioma, they will take the whole ovary out. And when you take the ovary out, if you lose one egg, you are losing half of your egg supply, and that is irreversible. So from a fertility perspective, the last thing on the planet we want to do is take an ovary out. Okay, now, if we see little implants of endometriosis on the surface of the peritoneum, on the lining of the peritoneal cavity, we will tend to vaporize those as opposed to excise them. Why? If I just told you a minute ago that excision of an endometrioma is better than vaporization, why would I now be changing my mind? The answer is because with little implants of endometriosis, if you excise that, if you cut that lesion out, you create a large area of raw tissue that can be a source of scar tissue formation. So it's been shown in several studies that vaporizing little implants of endometriosis is actually superior to cutting out a big area and leaving that area to scar and stick to other things. So does each laparoscopy done cause your eggs to diminish? This patient has had 3 laparoscopies since 2017. It depends on what was done. If you just had endometriosis around the ovary, on the sidewall of the pelvis, on the uterus, at the top of the vagina, if that was vaporized, that has nothing to do with your egg supply. Won't diminish it at all. If you have endometriosis on the surface of the ovary vaporized, okay, that may minimally disrupt your ovarian egg reserve, okay? If, on the other hand, you've had a big incision made in your ovary because you have a big cyst, and that cyst has been removed, that can compromise your egg supply to some degree. But even still, we believe that if you've got a big endometrioma, that it is much better to take that chance than to try and conceive with an endometrioma in place or ignore it. We know that any stage of endometriosis, even minimal disease, is going to decrease your chance for treatment. No matter what we do, it's going to decrease your chance for fertility with any treatment by 30 to 35%. If you have more advanced disease, it may decrease it even by more than that. And we also know that endometriosis, based on the stage of disease, that defines the recurrence risk. So we know that stage 1 or stage 2, minimal or mild endometriosis, there is a 50% recurrence risk in 4 years. Okay, that means within 4 years, if you have not gotten pregnant in the meantime, there's a 50-50 chance your endometriosis will come back. And why do I say it like that? Because as I said before, pregnancy is the best treatment of all for endometriosis. And there's a lot of data that suggests that with minimal or mild disease, once you're pregnant, you may never hear from endometriosis again. There are even studies that suggest with stage 3 or stage 4 disease, where the recurrence is even more common. It's 75% risk of recurrence in 2 years without pregnancy. But there are even studies that suggest that if you get pregnant with stage 3 or stage 4 disease, even if it takes IVF to do it, your risk of endometriosis will be significantly diminished. So treatment of endometriosis is very, very important. If someone hasn't conceived naturally in 6 years and can't afford IVF, what do you recommend she do naturally to help fertility? Lots of things that she can do, because there's lots of treatments besides IVF. I would encourage you to go see a fertility specialist. Seeing a fertility specialist shouldn't be much more expensive than going to see a general gynecologist, but fertility doctors have lots of tricks up our sleeves. We've got lots of potential treatments available to help you conceive. What is the window of time to surgically address endometriosis before proceeding with an IUI or an IVF? It really depends. Certainly, if you're going to do IUI and use your fallopian tubes, I would absolutely encourage you, if you're having symptoms or you're worried about endometriosis, to have a laparoscopy sooner rather than later. You're going to need about a cycle, about 1 month or so, for your pelvis to heal before you want to progress to IUI. If you're doing in vitro fertilization, again, it depends. Okay, if you've got an endometrioma, that endometrioma, in my opinion, should probably be removed before IVF stimulation. Why? Because it's taking up a significant amount of room in your ovary, and that's less real estate where we can get eggs to develop. So several studies have shown that it's worth the potential hit to your egg supply to get that endometrioma removed, to free that ovary up of any impediments to being able to make eggs. So my recommendation typically is, if you've got a big endometrioma, it really should be removed before you do IVF. Now, if you've got a little endometrioma, some doctors will recommend stimulating around it. Sometimes we recommend that as well. But on the other hand, you're probably going to want to get that endometrioma treated before you do an embryo transfer. Why? Again, like I said before, endometriosis makes these cytokines that can interfere with implantation. So I published a study several years ago with Eric Surrey and Bill Schoolcraft, and we looked at women who had stage 3 and stage 4 endometriosis. We randomized them. We took them all to laparoscopy. We got rid of their endometriomas, and then we randomized them. Half of them went right away to IVF with embryo transfer. Half of them had 3 months of Depo Lupron treatment before IVF. And the pregnancy and delivery rate was actually statistically significantly higher in the women who had 3 months of Depo Lupron. So therefore, we believe that if you've got severe disease, it's reasonable to go ahead and get your endometriosis treated, and then go on Depo Lupron to make sure that any residual disease is addressed medically before you proceed on to IVF. Last question that we've got, and this is going to time out nicely because we're almost done. Do you have to wait to try naturally to get pregnant after laparoscopic surgery? We would advise you, again, it depends on what was done. If you have a laparoscopy and there's minimal disease there, no, you don't have to wait. If, on the other hand, you had surgery to remove scar tissue around your fallopian tubes, those tubes may swell, which may raise your risk of an ectopic pregnancy or a tubal pregnancy for maybe 2 to 3 weeks. So we would advise you to sit out one cycle if you've had any significant surgical procedures done on the tubes or the ovaries before you try and conceive. A lot of stuff to cover in 59.5 minutes. So I hope that you have found this valuable. I hope you found this helpful. I would strongly encourage you to talk to your individual physicians if you think that you have endometriosis. It is a treatable condition. Unfortunately, endometriosis is not a curable condition. It's a lifelong condition. Most people will have their endometriosis go away after either pregnancy or most people after menopause. But like I said before, 6% of people, even after menopause, that's surgically induced or natural, will continue to have symptoms. So if you have endometriosis, please go see somebody and be treated. I wish you all the best. If I can be of any help, Dr. Kaylen Silverberg, Texas Fertility Center, www.txfertility.com. Thank you so much. Have a terrific evening, and thanks so much for joining us.